what I will try to do is to talk about the overview of myopia and options as an intervention. So some of the options are already available in most part of the world, but we do understand due to regulatory, some lenses like auto-K lenses are not available in Thailand at this point in time. So then we will talk about other options as well, which is, later I'll share a bit more some of these options that I think is probably more practical for a Thailand market. So by 2050, we talk a lot about these numbers. So half of the world's population, what will happen by 2050? So we will probably have like a 5 billion kind of people, but then almost 50%, half the world population will be myopic, okay? And almost 1 billion people will have high myopes, which is, we're talking about -5 diopts and above. So we are looking at a pretty serious condition whereby some countries will probably suffer more from these statistics. Some countries will do better in terms of lower myopic condition within the population in the country itself. But again, as you look at across the board, every country will probably have a high incidence of myopia within the country itself by 2050. Partly, a lot is probably driven by digital devices, close contact with digital devices on children that will really worsen the myopic condition of the population as a whole. So this is an issue that eye care practitioner or the industry player, we are all looking at, and possibly hopefully to control this down as well. If you could mute your mic, because I'm also hearing echo coming from sorry, if you can, do help me mute the okay, thank you. I'm hearing myself. It's a lag delay, so I'm hearing myself on the microphone. So thank you so much for helping me to mute your mic. Thank you. Okay, I'll just continue going on. So it's an issue that we all have to grapple with and to probably find some solution out of it as well. Okay, so as all myopia, there is some risk factors, like age, younger than 13 years old, and there's a history of family history of one myopic parent, likelihood the child will be myopic as well, and also children are getting less and less outdoor playtime, or just spending less outdoor. So again, it will worsen the myopia condition as well. Time spent on near work, whether is it on books or on digital devices, that will also worsen the condition. And of course, reflective error, less plus refraction than expected for age. Okay, that will also be another factor for worsening of myopic condition. Okay, if you see the graph here, you see if two parents are myopic, you see the probability of the child being myopic is also is much higher than parent that is not myopic. So again, these are the factors that we all have to look at and also to probably work along to reduce the rate of myopia within the country or in the practice that we practice with, or the patients that we deal with as well. Okay, and a bit more reflective error in detail. Young children are expected to be hyperopic, and the expected normal is +1 at 6 years of age. So less plus refraction, like I said earlier, for expected age is a risk factor for myopia. So if you look at the chart there, depending on age, so you have less plus, you tend to have a higher incidence of developing myopia at an early stage or a younger age. Okay, so and the younger the child becomes myopic, the faster they will progress in terms of the myopia progression. So for example, onset of 7 years old, they will progress by 0.9 diopters every year. See, let's say the child onset at 12 years old with myopia condition, they progress at a 0.3 diopters per year. So again, if you do your math, if you add those numbers up every year, 0.9 or 0.3, it becomes a very high myopic at maybe 15 years old or 16 years old, which is something that we know, or you could know you have a reflective error of -6 diopters by 16 years old. So this is something that we want to reduce or to manage or to control, as we talk about it. And what happens in the myopia control progression? Next part is the fastest rate of reflective change in myopia children occurs in the year prior to onset. So if you look at the chart here, so this is the onset year, but prior to onset, you see the biggest rate of reflective error jumping. So this is a part where actually don't wait for the child to have reflective error. Before the onset, preventive measure can be done. Okay, so this is the important point that as an eye care practitioner, possibly when we look at our patient, we have to look at them differently. And a child who is less hyperopic than normal age should be also be closely monitored. And of course, there's greater need if other risk factors are involved, like diet, premature babies. The child is a premature baby, so something to be monitored on, and less light exposure to UV ray, UV light. So these are a lot indoor. So these are the other risk factors that have to be considered when slowing the myopia progression of a child. So a lot of this has been talked about. What are the myopia risks? Glaucoma, of course, open angle, cataract, earlier to be involved in having cataract situation. Things like retina tearing due to the higher myopes, leading to a more serious condition like retina detachment. Of course, also we have talked about myopic macular degeneration. So these are all the risks. It magnify with a higher myopes. So you see the risk level increases with a higher diopes. So again, it's important to slow down or to reduce the progression of myopes in a child. So the quick summary, less than 0.075 diopts or manifest hyperopic at age 6 to 7 is the most significant factor for future myope. Okay, and essentially, any myopic child is a progressor until proven otherwise. So basically, this is an important point. So any child that comes to your practice today is basically a progressor until proven otherwise. So we are saying any kids that come to your child, they will definitely progress in a myopic condition until you do certain things that is differently from what they are doing today. And the institution of myopia control strategy as early as possible is really evidence-based practice. So don't be afraid to tell your patient to start a myopia control in some way as early as possible. It's not frightening a patient, but really this is an evidence-based practice, and this is important, especially by the age 9 years. So you can actually start any form of myopia control strategy. Later on, I have a slide on that to talk about what are the strategy that you can involve in getting a myopia control strategy implemented. So if I'm going to look at individual practices as a whole, what is the current actual myopia practice? So we have myopia control, contact lens, single vision. So what will be the portion of that falling into place? So the big gray area is single vision lens. So I would say majority of practitioners today, in most part of the country, I'm sure in Thailand as well, most easiest way to treat children with myopia is single vision spectacle lens. So that's a big part of it. Okay, and then maybe some will treat with contact lenses. So feed the child with contact lenses, a smaller portion of it. But really, how many practices will really embark on a myopia, actively embarking on a myopia control strategy or myopia control practice within the practice itself? So the blue part, really very small. But again, that blue part is small. That means we have a blue ocean there that we can actually expand this part within our practice itself. Can we do better? Can we enlarge our myopia control practice, to be a bigger portion within our practice itself? So this is a question that all of us, as a practitioner, we have to ask. As an industry, how can we also influence that as well? So again, another important point to think about. Now, do we want to start more myopia control as part of practice? So the goal of myopia management is really to reduce axial elongation as much as possible during the development of the myopia. So an axial elongation is really associated with retinal pathology. So at the end of the day, whatever strategy we are implementing, we want to reduce the axial elongation as much as possible when the child starts to have an onset of development of reflective error. you can actually take note of this. There are some myopia management resources. I'm quoting this from Brian Holden Vision Institute. So there's a link there, the global myopia center.org, myopia resources, myopia guideline. So you can write this down, and hopefully our videos are recorded. So later on we can share this video as well if you want to take a look. We can sign up there, and actually with that you can actually key in your patient age and the current myopia, and then there's a very nice map to show 12 years old, 13 years old, likelihood of where your patient myopia will be at. And you can use this to actually to talk to your patient, say, hey, potentially your risk 4 years down the road when your child is 12 years old or 16 years old, we are looking at myopes of -4, -3, -6, for example. So it's a very good tool to actually to explain to the parents, and also make the parents more actively involved in having a myopia control strategy implemented. So it's not enough just having the practitioner telling the parents, but the parents must also be able to see that very clearly. So things like that, which is really important. You can actually use it to have that. So some of the assessment of risk I explained a lot, like parental myopia, refractive error, near work use, outdoor time limited. So what's the increased risk of progression? So these are all there. So it's actually a good tool to use as a reference point in your practice if you want to use that. Okay. So as a myopia control management, what can be done, or what we can have a status quo situation as well. So if you have no myopia control strategy, so basically if you don't do that, what do? At least do increase outdoor timing. Tell the child to have more outdoor timing, have more regular frequent breaks from near work. But let's say you have there's no myopia part. Okay, so you do all this to reduce the risk when the onset of myopia is not there. But let's say there's myopia starts to take place. So probably we need to consider a myopia control strategy involved, looking at patient suitability, what is the risk of progression, looking at what is the patient career preference, the effectiveness of the strategy, and ability to access to the strategy. It could be finances, ability to access, because some of this strategy involve buying certain, the parents have to pay for certain things, which might be difficult as well. And also access to the strategy could be regulatory within the market as well. Okay, so if in that strategy you have no control, like the map that I have earlier, basically using a single vision spectacle lenses, okay, or single vision contact lenses, okay, basically not having any control. Let's say if you want to do a more active control to reduce the onset of progression in your patients, what are the options available? If you look at contact lenses, okay, we can have like a myopia focal light, like center distance kind of a contact lens to use as a myopia control lens, or you can have like a extended depth of focus contact lens, which Jerry will talk a bit more. Of course, there's auto K lenses available in a lot of markets, but in Thailand, unfortunately, it's not available yet. And of course, you have progressive additional spectacle. People from Essilor, from Carl Zeiss, they have it. Myoplugs, Myovision. These are another example. So, of course, you have executive bifocus. So the efficacies of all these examples, some are really high in terms of efficacy. Some are really makes better than have nothing. You can try some of this option. So things like a peripheral defocal, atropine, of course, is a very effective way of controlling, but then there's a limits on how it can be used. And now, of course, you can have a combination of both low dose atropine and also with the usage of contact lenses, whether it's the EDOF lenses or even auto K lenses. Okay. So if I look at what are the efficacy of the different options, so if you look at using a like a myopia control kind of a spectacle lens, we're looking at probably 29 to 45% of efficacy. Basically, the whole principle of using things like that, myopia control spectacle lens, is reduce accommodative lag or reduce hyperopic peripheral defocus. So there's an element of peripheral defocus going on in those kind of spectacle lenses. So it's simple, non-invasive, no rebound effects, and it's also the field of view is good. No, field of view is not so good, and of course it's have an element of bifocal in it, so the vision could in somewhat be not as good. So they have things like multifocal soft contact lenses. So you might be looking at 49% efficacy. Again, working on the principle of a hyperopic peripheral defocus. A wide field of view, look good. You can play sports on that as well. But it might have a lower quality vision because of the ad being built into the vision optics. So and also wearing contact lens, you have a small risk of microbial keratitis. If you have dry eyes, then it might not be so suitable. Things like auto K, again, auto K has a very high, though it's 43 now percent, but then the other studies show there's a very high efficacy, as close as 60 to 70%, depending on what kind of studies you're looking at. Again, you reduce relative hyperopic peripheral defocus. No need to wear any correction during the daytime. Wide field of view, good aesthetic, good in sports. But again, and other risks, the risks involved with wearing contact lens apply as well. Okay. And also you might have a low quality of vision, particularly with large pupil. Okay, and of course using atropine, which is a lot of eye doctors prescribe that. So it's a well-known it's a good mechanism used in a lot of countries. It reflects the eye focusing mechanism by disabling it. It's a very good myopia control tool and likely to have good VA when used with a single vision correction aid. But again, the drawback of that is the downside of any treatment sometimes is the duration of treatment cannot be too long, the dosage cannot be too high, okay, and it can dilate the pupil. So again, these are some of the things that have to be looked at. And also, we do see studies after atropine is being discontinued, the rebound gets also quite rapid as well in terms of the myopia correction. So something that we have to look at. So having said all this, what are the options available within the country itself that we probably have to look at and to say what is sensible and what's not sensible? So things like spectacle lens is really good, easy to use. Auto K lens, getting product regulatory might be a challenge. Okay, something have to be worked at. Of course, eye doctors use atropine. Depending if you are eye doctor or depending on regulatory, some eye care practitioners and optometrists are not allowed to use atropine. So again, depending on the local regulatory situation in terms of applying drugs to the patient. So the next part we want to talk about is EDOF. So EDOF is really a good lens in terms of as a myopia control tool. So it's really easy to fit versus auto K lenses, and it has demonstrated myopia control efficacy, provide better vision versus multifocal contact lens for young myopes. Excellent aesthetic, it's reversible and it's one day disposable, and it's also an excellent fast free option for young myopes. And another point here is I didn't put that down because EDOF is used as a presbyopia lens mainly and then for myopia control or myopia strategy is used as an off-label lens. To get that approved in Thailand is actually a lot more easier. Which probably is probably more positive as a presbyopia lens, and use it as a off-label myopia control lens usage within the clinic practice. So there's probably a much better and much effective way of having some level of a myopia control tool being put into the hands of Thai optometrists or Thai eye care practitioners with like a lens like an EDOF. So Jerry will talk a lot of that as well later on.
We'll look through the science behind EDOF before we get to know how SIT one-day EDOF lens designs suitable for presbyopic patients. We will then move to another age group, how we use EDOF in myopia management. I have some clinical studies to share with you all. EDOF means the design intends to extend the focus depth and increase the range that human eye can see. EDOF technology is now widely accepted and fitted by the ophthalmologists. In the IOL industry, there are low additional power, spatial diffractive designs, sphere aberrations control, and pinhole, all these lenses can be called EDOF lens. Recently, there is a EDOF contact lens named Natural View, which made by American company, which is central distance design. However, this lens was approved as myopia control lens, not for presbyopia patients. Here is a simple picture that shows the optical system of single vision. You can see after the refraction from the lens, the light will focus on the focal plane. The range in the yellow color means the depth of focus. It is narrow. When we look at distance, a perfect acuity is seen at the distance focal point. Due to the shallow depth of focus, everything from near to intermediate remains blurry. When we read at arm length, the letters are in focus. You can still see the objects around the book, but it's not as sharp as the letters. This is what we call depth of focus. Another question comes in, can we increase the range of focus? Can we extend the depth of focus? The most simple EDOF design, which we all know is bifocal design, which sets two power on the optical zone, which provide distance and near vision in one lens. When the difference between the distance and near is bigger than 0.5 diopter, usually the intermediate quality of vision will decrease. So we'll see more deeper into SID one day pure EDOF lens design. Brian Holden and SID have developed and commercialized an algorithm that unlocks the full potential of optical characteristics and visual properties. By applying this algorithm to the lens design, EDOF lenses are able to minimize variability in visual performance, overcoming the limitation of traditional multifocal contact lens and providing a good options for myopia management. EDOF also provides a good perceived image quality under a broad range of conditions. In SID EDOF lens, there are three individual lens design with 3 edition power, plus 0.75, the low edition, plus 1.5, the middle edition, plus 225, the high edition. This diagram shows aperiodic rings in it. Non-monotonic designs, which means the power distribution is not increasing or decreasing in a consistent way. So when you look at this diagram, try to recall the physics theory on light refraction. When a light wavefront passes through a lens, it will refract towards the focal point. The depth of focus is limited and shallow. What we apply in SID EDOF lens is actually manipulating a few higher order aberration, refracting from the lens, and focus on the focal points as well. By using this method and referring to the principle of interference, they are able to focus on the focal points in the red line, and this is how the depth of focus is extended. With the extended depth of focus, it is likely to have a more balanced visual performance from far to near. It is less likely to be affected by pupil size changes and decentration. This is the comparison of different designs of multifocal contact lens, which easily be affected by different conditions. So this is another studies that done by Brian Holden. We look at the effect of pupil size on optical performance. Different line color represents different pupil size. So you can see the EDOF lens is less affected by the pupil size. So whether they look at far or near, or the pupil size change from small to bigger. So the retinal image quality remains high in 3 different designs too. Same goes to decentration on the EDOF optical performance. So EDOF lens are able to give the higher retinal image quality in low, mid, high. So this is the visual performance illustrations when the patients wear EDOF lenses. So from far to near, there is a well balance of vision quality. So there are 3 lenses designed for 3 different depth of focus ranges. Each design features extended depth of focus and provides the power distribution needed to give a more balanced image quality from near to far. It is a true extended depth of focus lens rather than classifying it as central distance or central near lens design. A lens with high depth of focus offers the widest range of depth of focus. The perceived image quality is best with the low depth of focus type. So do you remember what EDOF stands for? The EDOF lens provides a good retinal image quality at all distances throughout the range of depth of focus. It is a true EDOF design which can provide presbyopia patients with continuous and stable quality of vision. EDOF lens strongly defends the effect of pupil size. The vision is stable with lens decentration. So let's see how EDOF can act as a myopia control lens by using the middle addition power. So these are the famous myopia management in the industry. Some practitioners are using the spectacles, contact lenses either in soft type or rigid type. And some doctors to use atropine to reduce the myopia progression. And the extended depth of focus can be up to 72 efficacy in reducing the myopia progressions. So this is what we already know in myopia management so far. At birth, the optics of an eye is not matched to its axial length. The kids will have a process called emmetropization by homeostatic growth control mechanism. If any failure of this will result in refractive error. It is suggested that the multifocal contact lens would give a peripheral myopia defocus, which is a potential way to slow down the myopia progression. So in myopia management, the peripheral hyperopic defocus could trigger the axial length growth. Even in autocare treatment, they suggest that this would shift the hyperopic defocus back towards the retina. So a plus lens could induce a myopic defocus. So let's look at the clinical studies. So there have been 3 studies conducted. The first study, they will look at the visual performance acceptability in 1 week dispensing. So they will look at the subjective vision and their feedback. And the second studies will be the myopia progressions. They will observe the 2 years efficacy. And the third studies will be the myopia progression in 6 months comparative, which involve 3 groups of people wearing a single vision lens. Okay, one eye is single vision lens, the other eye could be a multifocal lens. So in study 1, they started collecting data from participants, had them to wear 4 types of lenses in random, So they will collect the data and do the necessary checking. And also after 7 days, they will collect the subjective response. So in case there is any drop out or suddenly stop, they will repeat or even wash out. So they collected the data. So the yellow color and the orange color represents the EDOF lenses. Okay, so you could see that the overall performance, actually the EDOF lenses perform better than MiSight and ProClear. So in another study, which involved 523 participants, which involved the young myopes, children. So these are the test contact lens they will use, have them to wear a different lenses and single vision act as a control lens. So they will progress the studies with 2-year follow-up. So the reduced hyperopic defocus means that they did not reveal what type of multifocal lens. So, but this is the multifocal lens with different designs, and this is the EDOF lenses design. So middle and low edition. So they have shown the results, axial length and spherical equivalent respectively. So the data shows that the axial length progression and spherical equivalence in using the EDOF lens has significantly slowed the myopia progression. So in terms of subjective results, their feedback, the EDOF lenses actually perform similar to single vision lenses, which means the young kids can accept the vision quality in EDOF if they wear single vision comparing. So there is no issues of switching them from single vision lens to EDOF lenses. So there is some drop-out cases from the numbers of participants. So the time and job conflict, which could be the main issues for the drop-out cases, and others is not stated. So in summary, from the study 2, the EDOF contact lens shows a significant myopia control efficacy compared to single vision control contact lens. The myopia control efficacy is not significantly different between the two EDOF designs. The visual acuity reduction with EDOF lenses is actually less than 1 line. And the subjective vision is no difference between EDOF lenses and the single vision control contact lens. In study number 3, they involved 95 participants, also young kids. They have 3 groups. The first group is wearing the both eyes with single vision. So this is the baseline. So they will come back follow up in the first 6 months and the second 6 months. In group 3, they will have one eye wearing the single vision and the other eye wearing the MiSight, while the group 3 is wearing the single vision and the other eye is wearing the EDOF lenses. So after the 6 months, they will actually switch the lenses between the eyes. Meaning that if the initial eye is wearing single vision, they will wear the EDOF lenses after 6 months. So this is the results in the first 6 months after the first 6 months follow up. So in single vision, actually, there is shown that the axial length is elongating, and the spherical equivalence is actually become worsened. So with the MiSight or the EDOF lenses, actually there is still some efficacy. In MiSight, there is 48%, around 40% of the efficacy, while the EDOF lenses has 63 and about 40% of efficacy in spherical equivalence. So let us look at the second 6 months if they about to switch on the contact lenses between the eyes. So my side is still showing about the 30% to 42% efficacy, while the EDOF lenses, okay, showing the 64% and 66%, which means that there's less slowing with my side lenses in period 2 compared to period 1. So the EDOF lens performs similarly, either regardless of time frame. So in summary, EDOF lens is confirmed a potential and solution for myopia control because they demonstrated the myopia control efficacy, and it provides better vision if compared to the traditional multifocal contact lens for young myopes. So this is the EDOF lens specifications. So this is a hydrogel lens, daily lens, diameter, center thickness, base curve is 8.4, and the water content is 58%. DKOT for the 2.9. The spherical power, okay, is +5 to -12, and each power is in increment is in 0.25 steps. 3 designs, low, middle, high, and there is 32 lenses in the box. So this is the lens marking. All right, so thank you for your time for this topic. Now I will show you a video of the interview of an eye care practitioner in Australia, Dr. Oliver Wu.
Okay, so Dr. Oliver Wu here. Dr. Oliver Wu from Sydney, Australia. He's one of the very experienced fitters in Australia, and I'm very privileged to have him to share a little bit about his experience with the EDOF lens. So, Dr. Wu, how long have you used the slit EDOF lens for?
Oh, probably about 5 to 6 months since the beginning of this year. Yeah, the really good lenses. Yeah, good to have extra option lenses in my practice for my patient needs, in visual needs.
Oh, excellent. Okay, so how have you found the lens in terms of comfort and vision so far?
So far, the comfort, the visions, I would say probably 80–90% of them are really happy with the comfort, with the visions. Depends on what I use it for. Okay, probably we know EDOF lenses can have lots of different options in fitting the visual needs or some special requirements that we can use it for. Yeah.
Okay, so which patients are the ones that you fit the EDOF lens for at the moment?
Currently I'm fitting like presbyopic, like EDOF we know is more for presbyopia, and also I use it for my myopia management use for the kids. But have to make sure we know this lens I use it as an off-label usage for the myopia management.
Yep.
Yeah.
Okay. Yep. And what about the success rate? How are you finding that for your presbyopia and myopia management?
For the presbyopia, we're really happy. Seriously, we're happy with the success, right? Like I said to a lot of our friends, make sure you follow the fitting guide. So if you follow the fitting guide, the success rate is pretty high. I would say for the presbyopia, probably close about probably 70–80%. Okay. The success rate quite good, and people are quite happy. And need a bit more chair time to fine tune a bit of the like the extra 025, a little bit high, and I mean mid, low, a little bit chair time. Probably I would say sometimes you might need about 2 to 3 visits to get them really right. I think very similar to other multifocal soft contact lenses, you need about 2 to 3 visits to make sure. And for the myopia management, I'm pretty comfortable to use it as another option for my myopia management option for the kids. And so far, all the kids are really happy, and with the vision, with the comfort. And I would only can say it's a bit too early to say whether it's really superior than the other options, because I only use it for about 4 or 5 months. And we still need a lot of data, a lot of clinical numbers to tell how good the EDOF lenses, like the CEDOF lenses in the myopia management bracket off-label use. Okay, make sure you know what I'm talking about. Off-label use there.
But it's so far so good.
So far, so good. I'm really happy with this. Yeah.
Okay. So would you say that the EDOF lens is a valuable addition to your practice?
Yeah, I think not just to my practice. I think will be a really good, valuable option for everyone can have access to their practice in both presbyopic side and myopia management side, and also really good lens that you can add value to your practice and also build your practice from a different category.
Okay.
Yeah.
Well, anything else you want to add?
Yeah, I think be more adventurous and open your arms to try different things. Okay, and you will see more different well when you open your hands, open your arms to try different things. Good.
Excellent. Well,
Okay.
Thank you for your time.
Thank you. No problem.
Okay.
Look at the UV1, the slit RGP lenses. Throughout the presentation, I will do a brief introduction on RGP, how to select the suitable patients for RGP, and how to handle the RGP and the lens care system. We will focus on slit RGP, we name it UV1. We will look deeper into the lens design and materials. I will share how to fit with UV1 and share some troubleshooting. PMMA as an original RGP material because it gives the good optical stability and durability. Slowly improvement of the materials from silicon acrylic to fluorosilicon acrylic, which improve the oxygen transmissibility and reduce the protein deposition. Some RGP lenses can have surface treatment. Some can include the tip and UV blocker. RGP actually brings a lot of benefits towards the wearer. It provides the excellent vision and correct most of the vision problems and even high astigmatisms or the initial stage of the keratoconus. It requires a short adaptation period and it is easy to put on and take care and comfortable to wear due to the size. So some practitioners are using it for myopia control as well. It is available in multifocals or bifocal designs. It retains shapes and easy for handling. So it is suitable for those who cannot adapt to soft contact lens. And it's durable and it does not have water content. Of course, there is some limitations for RGP, but this is all can be overcome. To maintain the adaptation, they require consistent wear. And due to the smaller size, some tend to slip off the center of the eye easily, but most of the wearers are comfortable with it. Sometimes the debris can get under the lens, so the lens maintenance is very important. They will require a regular office visit to check on their eyes condition and the lens conditions to make sure both are in very good conditions. Here is some good points of soft and RGP lenses. You can advise them depends on their lifestyle, occupations, working environments, eye conditions, because some depends on their lifestyle. Some, if let's say they are actively, so you would recommend them soft contact lens rather than RGP. So please select the patients wisely before you fit the RGP on the patients or recommending the GP lenses to potential patients because we do not want anything happen to their eyes. You will need to consider their optical indications, either regular or irregular corneal astigmatisms, or high amounts of refractive errors, high astig. So in keratoconus patients, they are all a very good candidate to wear the GP lenses. Also, you need to be very sure that the patients do not have corneal injury or any infections on the lids or eyes infections. If they have dry eyes, please treat the dry eye first. If they are developing the cataract, so you would recommend surgery rather than replacing the new lenses to the patients. So make sure they do not have any inflammation of the eyes or the lids. And you will need to look at their personal hygiene, whether they have long nails. So this would be dangerous if they accidentally poke their cornea. So your patient motivation can encourage them to be a very successful RGP wearers, especially when it comes to cleaning parts. You can manage their expectation on the lens condition, performance, and eye conditions, because maybe the soft lenses and the GP lenses, the price a bit slightly different, so they will expect more from the GP lenses. So here are the two useful ways to put on and take off the lenses. This will require you as an eye care practitioner to teach them. So this might take some time, and please be patient with them. So to keep the lens condition good, we advise them to use the solution which meant for RGP. You can get it from Slit or Boston. Both are compatible for RGP, for UV1 as well. So now let me introduce the Slit UV1 to you all. Slit UV1 is able to cut the harmful effects from UV radiation. UV rays can be divided into three types. UVC, which is completely absorbed by the ozone layer and atmosphere. UVB is mostly absorbed by the ozone layer, but some still reaching the Earth's surface. UVA is not absorbed by the ozone layer. In the market, there is some non-UV cutting lenses, while Slit UV1 can block 98% of UVB and up to 87% of UVA. So let us look at the experiments. The purple part shows the cornea epithelial cells, and before and after exposure to the UV rays. After exposure to the UV rays, in the lens, there is some purple color, which means the cells in the lens there's still few cells are still surviving in the lens portion. If the patient is wearing UV1, the epithelial cells are almost all survive. This gives a very good protection to our eyes. Wavelength, which is shorter than 280 nanometer, are completely absorbed by the cornea, and wavelength longer than 280 nanometer are mostly absorbed in the cornea as well. Only the remaining 1 to 2% of UV will still reaching the retina. So there will be the influence of UV radiation on eyes, such as ultraviolet keratitis, the inflammation of the cornea, and also developing the cataract. So this is the designs of our UV1. So let's look at the lens enlarged view, especially on the bevel side. So there's an outer bevel and the inner bevel. So for the inner bevel, that is actually divided into two steps, which is center curve, periphery curve. So this makes the lens ultra smooth. So every blink, you are not wearing the contact lens. This floating bevel designs can actually help the tears, circulation, and keep your eyes moist and comfortable all day long. So for the health of the eyes, we stick to the lens breathability, a comfortable fit, and protection from the UV rays. Slit UV1 is a well-balanced RGP lens designed by Slit. So this is the cross-section of the lens. So this is the optical zones, inner and outer optical zones. The central thickness is 0.17 millimeter. And this is the lens diameter. So this is the lens specification, the lens material, okay, containing silicon and fluorine. The decay is 60. The central thickness is 0.17 at 3 diopter. So it contains the UV blocker. And the base curve is from 5 millimeter to 9 millimeter. With each increment is 0.05 step. And the diameter is 7.5 to 10 millimeter. Each increment is 0.1 step. And the power you can order is plus 25 to minus 25. So before you fit the lens, you will require to check the refraction, the anterior segment of the eyes, and take some measurements, such as pupil size, BHVI, and visible palpebral aperture. The pupil size is to measure in normal and ambient light so that we know what is the maximum pupil size they will have. And the back optical zone diameter should be greater 1 mm than largest pupil diameter. So in HVID, the total diameter should be 1.5 to 2 mm less than the HVID, which is slightly smaller than the cornea. So if the lens is too large, it may induce a lid attachment. So you will see the lens is stationary at there. If the lid is too far from the limbus, it may induce the lens drooping. So after you fit the lens and let them have the short adaptation, so you will insert the fluorescent and do the slit lens examination. Usually we will do two types of assessment, which is static assessment and dynamic assessment. In static assessment, we will look at the lens, how it aligns to the cornea, what is their alignment pattern. With normally positioned, the lens should not overlap the limbus, and it should always remains at the center of the cornea. So in dynamic assessment, which means in dynamic, the meaning is lens movement. We will see how the lens move when blinking and after blink. Okay, and the lens should remain on the cornea during all gaze position. So we will held the lids apart and we will look at the lens movement. It should be slowly descended downwards, but it remains at the center. So each time you held apart, they should back to the center position. This is the ideal fit. Well, this is the fluorescent pattern that you will see in ideal fits, steep pattern or flat pattern. Okay, so in ideal fits, you can look at the edge lift. Is not too narrow, not too broad, and you can still see the pupil here. And there is tears underneath the lens. Okay, so in steep pattern, you will not see the pupil, and the edge lift is very narrow, which means that it is very tight on the cornea. And the central is pulling. In flat pattern, we will look at the central. Sometimes it will be very dark color because it is pressing on the cornea. And the edge lift is very broad, and you cannot even differentiate the the edge lift. So in ideal RGP fit, it should be a slight apical clearance, the mid-peripheral touch, and a narrow band edge clearance at the periphery to allow the tears exchange. So in smooth vertical movement, it should be about 1.0 to 1.5 millimeter movement with each blink. This to ensure that the debris is removed and also the tears oxygen exchange. The patients can tell you that the vision is stable and they feel they do not have so much of lens sensation. So this is the examples of flat fit characteristics. So the center is bearing, touching. So this could lead to the corneal aberration in the center. And the edge lift is very broad. You can see here, the fluorescent is channeling. And you can observe the excessive movement on the blinking or even very easily to drop out. They will complain that they have a very poor comfort and the vision is not consistent. So some will have excessive tearing as well, even after adaptation. So in steep fit, the central pulling under the lens in the center due to the excessive fluorescence and tears. So sometimes you can see a bubbles in here, trapping it. Okay, and the edge clearance is very, very narrow. And the movement you can actually didn't see at all because it's very tight. Sitting too tight on the cornea, it don't move. Okay, so some will say that there is no lens saturation as well. Some even say that, oh, they feel comfortable with it. But when you look at the pattern, you know it's thick pattern. So you will do some changes on the lens diameter. So there is also a possibility of cornea epithelial indentation caused by the age of the lens here. Just now, the flat fit will be in the center and causes the corneal abrasion at the center. So when you observe there is lens movement, either too much lens movement or too little lens movement, this is what you can change on the lens. So if you are about to increase the movement, which means that you see the movement is not, is very little movement, okay, which means the fitting is steep. So you will need to flatten the base curve or decrease the diameter. So if you see the movement, which is very excessive, you will need to decrease the movement by steepening the base curve or increase the total diameter. So there's some cases where you will encounter, if you straight away see this type of pattern, there's a bubble in the center and the narrow is actually it's very narrow. You straight away know that this is a steep pattern. You will straight away flatten the base curve. So in addition, you will if you encounter this type of patients, you will know straight away know this is a flat pattern. Okay, so center there's so much, and especially the edge clearance that's very broad. You know that this is a flat pattern. You will straight away steepen the base curve by one or two steps. So in some cases, you will encounter the cases like this. Okay, so you might know that sometimes you think this is a ideal pattern. Okay, so you need to consider the lens movement, the centration, and their complaints about it. So maybe you can try a flatter base curve and compare which is the best result. So in cases of lens decentration, you might encounter some high or low riding lenses. Okay, which means high riding, which means that the lens is always sitting up. Okay, so it suggests that it might be a steep fitting or the lens diameter is too large. So you need to flatten the lenses to let the lens comes down a bit. Okay, or reduce the diameter. Reducing the diameter will be slightly flatten the lens. All right. So for the low riding lenses, which means the lens is always at the inferior position of the cornea. So the lens may be too small. Okay, so we will increase the diameter. So in some cases, you will find that it's continually to one side, lateral decentration. So maybe the lens is too small or the lens is too flat, or the corneal apex is actually displaced, like in some keratoconus patients. All right, so you can increase the diameter or try and steepen the lens. If you find that the lenses is not moving at all, the lens is too steep and you need to flatten the lens. So in summary, RGP is an important sector for certain group of people. Although the market is small, but it provides superior optics and durability and stability. So step-by-step lens care system to maintain the hygiene of RGP And SIDS UV1 can cut off the harmful UV ray. And it has this unique design to maximize the various comfort and give the good tear circulations. So thank you, and that's all from me.